Welcome to the deep dive. If your blood tests suddenly show a dangerously high level of salt, the most logical assumption you could make is that you simply ate too much salt.
Right, yeah. You'd think, oh, I just had way too much sodium in my diet.
Exactly. But medically speaking, you would be almost certainly wrong. So today, we are looking at a stack of clinical literature that, well, it flips that assumption completely upside down.
It really does. It's a massive paradigm shift when you first encounter it.
Yeah, we are unpacking a condition called hypernatremia, and we're uncovering why this idea of high salt is actually a terrifying physiological detective story. It's about vanishing water, shrinking brain cells, and, the microscopic math that's keeping you alive.
We're looking at a pretty dense overview of the renal system today, along with a series of diagnostic pathways. And honestly, they all point to one fundamental truth.
Which is what?
That the human body is performing this relentless, just high-stakes balancing act.
Yeah.
And when that balance tips into hypernatremia, the consequences are immediate, and they are severe.
Okay, let's unpack this. Our baseline definition from the clinical data, the sources we have here, is that hypernatremia is a serum sodium level greater than 145 milliequivalents per liter.
Right, meaning the actual salt concentration in your blood is just too high.
But right off the bat, we really have to shatter that misconception about gaining salt. This condition, despite the name, is almost always about the body losing too much free water relative to your total body sodium.
Yeah, I mean, it is essentially a water deficit problem. That concentration effect is the entire key to understanding the pathology here.
So the sodium number on the lab report is going up strictly because the water volume is going down.
Exactly. The salt isn't really increasing, the water's just vanishing.
To visualize this, I keep thinking about a pot of soup simmering on the stove.
Oh, that's a good analogy.
Right. Like if you leave it boiling completely unattended for an hour, the broth becomes incredibly salty, but you never walked over and added more salt to the pot.
No, of course not.
As the water evaporates into the air, the physical amount of salt that was already in the pot stays exactly the same, but its concentration skyrockets, because it's dissolved in far less liquid.
The human vascular system acts much like that simmering pot. And what's fascinating here is that biology has this built-in alarm system to prevent the soup from boiling down.
So why don't we just, add more water to the pot before it gets to that point?
Well, normally we do. When your blood starts to become even slightly too concentrated, which is a state called hyperosmolality, your brain detects that the blood is getting thick.
Okay, so the brain notices the soup is boiling off.
Right. And it immediately triggers two things. First, it creates this profound sense of thirst, just completely compelling you to drink.
Which makes sense.
And second, it secretes a chemical messenger called ADH. That stands for antidiuretic hormone.
Which travels down to the kidneys, right, and essentially tells them to stank letting water leave the body.
Exactly. It forces the kidneys to reabsorb water back into the bloodstream rather than, flushing it out as urine.
So it's a two-pronged approach.
Yeah, this dual defense, seeking out new water by making you thirsty and hoarding the water you already have, it's highly effective. So sustained hypernatremia really only happens when that defense system is structurally broken.
Or, I guess, when appropriate water intake is physically impossible?
Yes, exactly.
Which perfectly explains the specific vulnerable populations highlighted in the medical literature we're looking at. Because this isn't a crisis that typically hits, a healthy adult just walking around a city with a water bottle.
No, definitely not.
The data points directly to infants who simply cannot vocalize their thirst, or the elderly, debilitated patients who might be bedbound.
Right, people who can't just get up and go to the tap.
Yeah, or individuals with an impaired mental status. If your brain's osmoreceptors are damaged and they don't trigger thirst, or if you physically cannot reach a glass of water, the soup inevitably starts to dangerously boil down.
And once that defense fails and hypernatremia really sets in, the medical team taking care of that patient has to step in and basically find the leak.
They have to play detective.
Exactly. They need to figure out exactly how and where that water escaped the body.
So we move from the cause to the investigation part of this. The diagnostic flowcharts we are looking at, they focus heavily on assessing the patient's ECF volume status.
Right, the extracellular fluid.
Yeah. So basically, the doctors are trying to figure out how much overall fluid is currently sitting outside the cells in the patient's body. And the flowchart splits these patients into three distinct buckets: hypovolemic, isovolemic, and hypervolemic.
That volume status is the crucial first clue, because it reveals the exact ratio of salt to water that the patient is actually lost.
But wait, if the whole problem is that we are losing water, how can someone be isovolemic, meaning normal volume, or hypervolemic, meaning high volume?
That is the tricky part. So let's break down the first bucket, hypovolemic. In this state, the patient's overall fluid volume has just crashed. They are actively losing both sodium and water from their body, but they are losing vastly more water than salt.
Okay, so it's a disproportionate loss.
Exactly. And the clinical pathways split that hypovolemic bucket further into two potential culprits: renal loss and extrarenal loss.
Renal meaning the kidneys.
Right. Renal loss means the kidneys themselves are the ones actively leaking the fluid. This could be driven by diuretic medications or kidney failure.
Or even severe hyperglycemia, right, where an excess of sugar in the blood physically drags the water out into the urine with it.
Exactly. The sugar acts like a magnet for the water.
Yep.
Now, extrarenal loss means the water is escaping somewhere else entirely, not the kidneys.
Like gastrointestinal disasters.
Yes, severe vomiting or diarrhea, or massive fluid loss through the skin from excessive sweating, or severe burns.
Or even respiratory losses like panting heavily from a high fever. That evaporates a lot of water.
It really does. So that's the hypovolemic bucket. Moving to the second bucket, isovolemic, presents a really interesting physiological scenario. The overall physical volume of fluid hasn't dropped as drastically as it does in the hypovolemic state. In this bucket, the patient is losing only free water. Their total body sodium stores remain completely intact.
So it's a pure water leak.
A pure leak. And that often comes from what we call insensible losses.
Which are what, exactly?
These are the fluid losses happening in the background that you can't really measure, like losing water vapor through your lungs with every single breath, or just steady, microscopic evaporation through the sweat glands.
Wow, okay. And the text mentions this bucket also includes a fascinating breakdown in chemical communication, something called diabetes insipidus.
Yes. Based on what we discussed about ADH, the antidiuretic hormone diabetes insipidus happens when that specific hormone is either missing entirely or the kidneys have just become completely resistant to its signal.
So the brain might be screaming at the kidneys to save water, but the message never connects.
Right. The kidneys are just deaf to it. So pure water just pours out into the urine.
That really highlights how fragile that chemical communication loop is.
It really does. And finally, we have the third bucket, hypervolemic, high volume.
Now, this is the one that really challenges our foundational rule. If hypovolemic and isovolemic are both driven by water loss, is there ever a scenario where the soup actually does get a massive dump of salt thrown into it?
Well, biology always has an exception, right? In hypervolemic hypernatremia, there is an actual physical excess of total body sodium.
Wow, okay.
Because there is such a massive influx of salt, the body frantically tries to dilute it by pulling water out of the surrounding tissues and into the bloodstream. And that dramatically expands that extracellular fluid volume.
But people aren't usually just, eating enough table salt to cause a medical crisis like this, are they?
No. The literature indicates this is almost always iatrogenic.
Meaning medically induced.
Right. A doctor or nurse might have administered highly concentrated hypertonic saline or a sodium bicarbonate through an IV during some other emergency.
Oh, I see.
Alternatively, it could be driven by severe endocrine misfires, conditions like Cushing's syndrome or primary hyperaldosteronism, where the body's hormones are inappropriately commanding the body to hoard sodium.
Okay, so we have our 3 buckets. But a doctor cannot just look at a patient lying in a hospital bed and know which bucket they belong in.
No, definitely not. They require biological receipts.
They need concrete data on how the body has been managing its fluid resources, over the last few hours or days.
Exactly.
And here's where it gets really interesting to me. The kidneys don't just process fluid. They leave this highly detailed chemical trail of breadcrumbs.
They do. They tell the whole story.
To definitively prove the source of the hypernatremia, the flowcharts rely heavily on laboratory studies of the urine, specifically urine osmolality, which is a measure of how concentrated the urine is, and urine sodium, which tracks exactly how much salt is being discarded.
Right. And if we connect this to the bigger picture, those laboratory numbers aren't just arbitrary digits for a chart. They are direct, measurable reflections of the body's survival mechanisms actively responding to a crisis.
Let's trace that logic for a second. Let's say I'm severely dehydrated because I've been suffering from intense vomiting for days.
Okay, so that is an extrarenal loss. The fluid is escaping through your gut, not your kidneys.
Right. Now, if my kidneys are healthy, I imagine they should realize the body is dangerously low on volume and immediately panic, right?
Absolutely.
They should go into absolute lockdown, hoarding every single drop of water and every grain of salt to keep my blood pressure up.
And the lab values for extrarenal loss reflect exactly that lockdown scenario.
Mm.
Because the kidneys are reabsorbing almost all the water, the resulting urine is incredibly dense.
Well, how dense?
Well, the diagnostic threshold shows a urine osmolality skyrocketing to greater than 600 millimoles per kilogram.
Wow.
Yeah. And because the kidney is aggressively clawing back all the sodium to help maintain blood volume, there is almost no salt left in the urine. The urine sodium drops below 20 milliequivalents per liter and often plunges below 10.
So highly concentrated urine with almost no salt in it proves the kidneys are functioning perfectly. They're desperately trying to compensate for a leak happening somewhere else in the body. But what happens if the kidneys themselves are the source of the leak?
Then the chemical breadcrumbs tell a completely different story. If it's a renal loss, say a diuretic medication is forcing the kidneys to flush out fluid, they are actively dumping sodium and water into the bladder.
So the numbers flip.
Right. The urine sodium will be elevated, sitting greater than 20, and the urine osmolality will hover in an intermediate range, somewhere between 300 and 600.
Because the kidney is physically incapable of fully concentrating the urine while that diuretic is forcing fluid through it.
You've got it.
And then we look at diabetes insipidus, where the kidneys are just completely ignoring the brain's ADH hormone.
Yeah, in that case, even though the blood is thick and salty and the patient is profoundly dehydrated, the urine labs show an osmolality of less than 300.
Which means it's super dilute.
Completely dilute. The kidneys are just continuously pouring out clear urine into the bladder because they aren't receiving the chemical mandate to stop.
The laboratory data really does paint a vivid picture of systemic failure, if you understand the underlying physiology.
It does. It's fascinating.
But the chemistry on the spreadsheet is one thing. We really need to talk about what is actually happening to the human being lying in the hospital bed.
Yes, the clinical manifestations.
Because they are overwhelmingly neurological. And there is an explanation of the mechanism in the text here that is genuinely chilling. It talks about the actual physical shrinkage of brain cells.
Yeah, that part is intense. We have to look at the physics of osmosis to understand why this happens.
Okay, remind me how osmosis works here.
Well, osmosis dictates that water will naturally move across a semi-permeable membrane from an area of lower salt concentration to an area of higher salt concentration. It's constantly trying to equalize the two sides.
So because the blood flowing through the brain is dangerously salty, it acts like a vacuum.
Exactly.
It literally sucks the water out of the surrounding brain tissue, across the cell membranes, and into the bloodstream to try and dilute itself.
And the physical result of that is that these cells of the brain lose their internal water volume. They literally shrink and pull away from the skull.
Wow. If the brain cells are physically shrinking, I imagine the symptoms aren't just feeling thirsty. You must see massive neurological misfires, right? Like confusion, lethargy, maybe even worse.
Oh, absolutely. It creates a rapid and progressive cascade of neurological decline. The initial profound thirst quickly gives way to severe disorientation, weakness, and hypertonia.
Hypertonia? What is that?
It's an abnormal, rigid tightness of the muscles as the neural pathways start to misfire. And the clinical literature warns that in severe cases, this physical cellular shrinkage leads to seizures, coma, permanent neurological damage, and eventually respiratory arrest.
That is terrifying. Plus, you have all the physical warning signs of severe systemic dehydration on top of that.
Right. The rest of the body is suffering too.
The text mentions patients experience orthostasis. That's where standing up causes their blood pressure to just plummet because there simply isn't enough fluid volume in the pipes to fight gravity.
Exactly. You also see tachycardia as the heart desperately beats faster to try and circulate what little fluid is left.
And delayed capillary refill in the extremities, plus decreased skin turgor, where if you pinch the skin, it stays tented instead of snapping back into place.
It is a profound systemic crisis.
Yeah.
So the medical team has to intervene immediately to restore the water balance.
But this intervention introduces what seems like one of the most delicate, heavily debated challenges in acute care. I mean, it's a real treatment tightrope.
It is a massive, fascinating debate in the medical literature about exactly how to fix this. and it centers entirely on speed.
Right. Because traditional physiological guidelines are incredibly strict about this.
Yeah.
They warn that correcting the sodium levels too quickly, specifically dropping the blood sodium by more than 0.5 milliequivalents per liter per hour, can trigger cerebral edema.
Which means the brain physically swells up.
Right. Why does that happen if we're just giving them the water they need?
The dried out sponge metaphor is the best way to understand this risk. Those shrunken brain cells we talked about, they have adjusted to the high salt environment. If a doctor suddenly floods the bloodstream with gallons of pure water, the osmosis reverses violently. The water rushes from the newly diluted blood back into the highly concentrated brain cells.
Oh, I see.
The cells aggressively pull that water in and they overexpand. And that leads to catastrophic swelling inside the rigid, unforgiving bone of the skull.
Wow. But then I look at the more recent clinical protocols referenced in the diagnostic sheets we have. They suggest a goal of dropping the serum sodium by 12 points over a 24-hour period.
Yes, the newer guidelines.
And they include this casual, almost startling note. Let me quote it. Accidental overcorrection unlikely to be dangerous. Complications of more rapid correction like cerebral edema are rare in adults.
It's quite a shift.
It feels like a massive philosophical conflict. The traditional guidelines treat rapid correction like a ticking time bomb, while the newer protocols suggest the adult brain is, well, far more resilient than we thought.
It really raises an important question about how medical guidelines evolve alongside clinical data. Well, the traditional textbook approach is heavily rooted in the absolute worst-case physiological outcome, right? The known, deadly mechanics of rapid fluid shifts.
Right, the sponge effect.
Exactly. But the newer protocols are incorporating decades of observational data. They're noting that while the mechanism for catastrophic brain swelling is absolutely real, the actual incidence of it happening from accidental overcorrection in adult patients is statistically quite rare.
So the clinician at the bedside is just walking this tightrope. They're stuck between leaving the brain dangerously shrunken and risking a rapid fluid shift that could cause it to swell.
They must proceed with calculated mathematical precision. Honestly, regardless of whether a doctor leans toward the highly conservative traditional approach or the more modern observational data, the treatment is never about just blindly hanging IV bags.
No guessing allowed.
None. It requires stabilizing the entire cardiovascular system first and then executing a very specific mathematical formula.
Well, let's talk about the math of rehydration, because it's surprisingly complex. If a patient arrives in that hypovolemic bucket, severely depleted, crashing blood pressure, the clinical pathways dictate you do not immediately give them the pure water they are missing.
That's right. Stabilizing the container takes absolute priority.
Stabilizing the container, I like that.
Yeah. If a patient is in hypovolemic shock, their cardiovascular system is collapsing. If you give them plain water, osmosis will pull that water straight out of the blood vessels and right into the tissue cells. It won't help their blood pressure at all.
So the first step is using isotonic fluids, things like normal saline or lactated ringers.
Correct.
Because these fluids have a salt concentration that mimics normal human blood, right? When you pump them into the veins, they don't trigger those massive fluid shifts into the cell.
Exactly. They stay inside the vascular pipes, plumping up the blood pressure and restoring circulation to the vital organs.
And once the cardiovascular collapse is reversed, and only then, the medical team pivots to fixing the actual hypernatremia. They finally replace the missing free water.
Yes, and the clinical preference is always to give plain water orally or through a feeding tube if the patient's gut is working.
But if it must be done intravenously,
Then they utilize hypotonic fluids, primarily something called D5W, which is simply a 5% dextrose sugar solution in pure water.
but calculating how much water to give requires solving for the free water deficit.
Yes, the FWD.
The clinical cheat sheets provide this standard shortcut formula. You take the patient's current sodium level, subtract their goal sodium level, and divide that resulting number by 3. And that provides the estimated deficit in liters.
Let's apply that just to see how it works.
Okay.
If a patient's sodium is dangerously high at 160, and the initial goal is to bring them down to a safer 145, the difference there is 15.
Right.
Divide 15 by 3, and the mathematical formula dictates a free water deficit of 5 liters.
So the doctor knows the patient is missing exactly 5 liters of water. But they can't just order 5 liters of D5W over the next 24 hours and walk away, right?
Absolutely not.
Because the patient isn't a static statue.
No, the mathematical target is constantly moving. That 5 liters only represents the water the patient was missing the exact moment their blood was drawn.
Right.
Over the next 24 hours, that patient will continue to breathe, sweat, and produce urine. You must account for those ongoing insensible losses we talked about earlier.
The physiological data breaks this down meticulously. A typical adult lying in a hospital bed loses roughly 700 to 900 milliliters of water a day, purely through the vapor in their breath and microscopic sweating.
That's almost a full liter just from existing.
Yeah. And that number escalates dramatically if the patient is battling a high fever, where heat aggressively evaporates fluid, or if they have massive burns compromising their skin barrier.
So the final prescription for the medical team requires daily dynamic calculation.
It's not a one-and-done math problem.
Not at all. The amount of free water administered today must equal the calculated free water deficit, plus the estimated insensible losses from breathing and sweating, plus every milliliter of fluid they lose in their urine over that specific 24-hour period.
Wow.
It requires constantly adjusting the IV drip rate based on real-time physiological feedback.
So what does this all mean for you? If we zoom out from the mathematical formulas and the laboratory thresholds, we've explored a profoundly complex biological system today.
We really have.
We've learned that hypernatremia isn't about consuming too much salt. It's a terrifying fundamental failure of the body's water conservation architecture. We've seen how clinicians hunt down the source of the leak by categorizing volume status and, analyzing the microscopic chemical receipts left in the urine.
And we've explored the sheer physics of osmosis pulling water from brain cells.
Yeah. And the delicate, heavily debated mathematical tightrope required to reinflate those cells safely.
The entire pathology just serves as a powerful reminder of how deeply interconnected our internal systems are. The neurological receptors in the brain, the filtration units in the kidneys, the fluid dynamics of the cardiovascular system, they're engaged in a constant, unbroken conversation.
Always adjusting.
Adjusting minute by minute to maintain that delicate equilibrium required for human life.
And it leaves me with this final thought for you to ponder. We all experience thirst. We experience it as a mundane annoyance. A dry mouth nudging us to grab a glass of water from the kitchen.
Right, it's just an everyday feeling.
But based on the staggering physiological mechanisms outlined in these clinical texts, thirst is actually a highly calibrated, critical neurological alarm system. It is literally the frontline defense standing between you and the physical osmotic shrinking of your brain cells.
It's incredible when you think about it that way.
It really is. So the next time you feel that dry mouth, take a second to appreciate the complex biological mathematics your brain and your kidneys are executing in the background just to keep you perfectly balanced and alive. Thank you for joining us on this deep dive. Drink your water, and we will catch you next time.